All right, so it's been a while. Back to the screencast for those of you at home. Luckily, we only really have one more set of notes, so you won't have to, or not one more set, we got a couple sets, so you won't have to worry about missing anything while you're home. So, big thing we're looking at next part of the unit is the therapy part. So, we're really looking to how do we treat these disorders. We'll go further in depth in the psychotherapies mentioned here, but main thing we're looking at is the biomedical, which will be a review of some of the medication, and then new ideas or presenting you with new information for the new types of therapy. So, there we go. So, different types of therapy we look at. Psychotherapy, obviously, this is going to be the talk therapy. Note, it does talk about something emotionally charged. So, obviously, there's going to be a level of trust that needs to develop between the patient and the therapist. But a lot of times, once this therapy starts going, it's not going to be necessarily during a very pleasant experience, because really you're getting down to the parts of the disorder that you may not want to accept, which would be the potential causes or the potential changes you need to make. So while at first it seems like it's really negative, at the end result there will be relief. And basically what this is going to operate on is on the idea, instead of letting things build up, you actually interact, confide, and talk to people. So this is something that obviously you could work on to actually be more open, more sharing, but obviously that's not necessarily one of the big components of us as humans. So the therapist provides that trusted, confiding person. Biomedical therapy, this is just basically either medicine or any types of medical procedures. So like when you look at, say, ECT or TMS, those are some things you're going to have to do at the hospital, but obviously like your medication you can take on your own. And then the light therapy for SAD, that is something you can also do. So this is going to be some type of either medical equipment, medicine, or a type of procedure that's done in the hospital. And then the eclectic approach, we either combine both biomedical and psychotherapy, or we will actually combine two different types of psychotherapy. So like combining humanistic and behavioral therapy, that would be a form of eclectic approach. Or like the new big component or the new big therapeutic technique that's successful is cognitive behavioral. And then cognitive behavioral would be a combination of two psychotherapies. That means it's eclectic. Basically, all this means is really showing us that these disorders are more complicated than usually just one type of treatment or one type of approach. Psychological therapies, we have basically four main ones. Psychoanalytic or psychodynamic. It's going to be referred to as psychodynamic really for the most part. But those are going to be really very similar, and we'll talk about some of the differences. Humanistic therapy or the humanistic theory, behavioral theory, and then the cognitive theory. Like the behavioral theory, you could look at some of the episodes of hoarding. You could look at some of the episodes of obsessed when they expose themselves to what they are fearful of or what causes them anxiety. That's a form of behavioral therapy. Now, obviously, the new ideas in therapies, we combine these two, and then we get to the patient usually will experience relief. And that could also be combined with medication, depending on the severity of the disorder. So biomedical therapies, is there any type of therapies aimed at altering body chemistry? They could involve shocking the brain to restart it, magnetic waves to restart it, or simply just providing some type of medication. Those are the main really looks at these. So when you look at psychopharmacology, this is the main form of our biomedical therapies, and this is just basically how the drugs affect the mind and behavior. So not only how the drugs affect the mind or the brain, but also the nervous system throughout the body. And this is any type of disorder that we 100% know is tied, or we think is 100% tied with a neurotransmitter malfunction. Your anxiety disorders, your mood disorders, and your schizophrenic disorders are going to be three of the main types are treated with medication. Now, even though we theorize that there is a neurotransmitter influence, that doesn't mean that this is going to be the cure. And that again shows the complexity of the disorder itself. If it was all 100% stimulated by neurotransmitter, biomedical or psychopharmacology would be the number one treatment. But we know that that's not always the number one treatment, so we usually use that eclectic approach combined with the psychopharmacology. So our first type of biomedical we look at, this is for seasonal affective disorder. Seasonal affective disorder, if you remember from your reading, it's really just the fact that you're more prone to depression in the winter months. And all that really signifies is our lack of vitamin D or lack of sunlight is actually causing the depression. So we will expose them to almost like a tanning bed solution type light. And you would have to sit in front of that type of bright light for so many hours a day. And notice, a lot of this is actually going to be increased in places like Seattle, where there's more overcast days than sunlight days, and even into your Alaska, where you go through months where there's very little daylight. We know this is scientifically validated, so we know one cause of depression is also just being shut up in winter months, and then you're shut in, and then also lack of light. Next one we look at is electroconvulsive therapy. This was widely used for like schizophrenic patients and more of your psychotic patients early in your 1930s, 1940s. This is not used widely. This is usually used as a last resort. And it's actually starting to show that it's working more for depression and mood disorders than anything else. But basically what is happening here, you'll see you have the electrodes stimulated to the brain. You have your EEG recording the brain waves. They're pumped with an anesthetic or anesthesia. They're put to sleep. And then the current is going to be passed through their body and brain for moments. It's going to stimulate a seizure. And the rationale is by shocking the brain and shocking the body, you're restarting your nervous system. And this would we do see some application because remember, your nervous system and your brain all use an electrochemical communication system. So this electro restart is designed to properly maintain proper amount neurotransmitter levels. Some people who do not respond to cognitive therapy or drugs swear by this. And so you're looking at probably less than 1% of the patients, and you're probably looking at a 0.01% of people who use this, but the people who use this will swear by this. And they will go in every 6 months. Usually at first they'll go in every monthly for maybe the first 6 months. And then realistically, it's about every 6 months they'll go in for this procedure, and they're let go as soon as they're up and ready and the anesthesia is out of their system. But this is a last ditch effort. Like, these are people who have a lot of suicidal type behavior. They may have tried to commit suicide multiple times. They may also have been institutionalized multiple times. And so this is the only thing they look at that is potentially working. It doesn't work for everybody, but some people who are severely, severely depressed will swear by it. And what we look at, the newer way they're doing this, and this is catching more ground, instead of using electroconvulsive waves or electrical waves, they'll use magnetic waves. Now, basically, the difference is you're not going to get a seizure here. They're not going to need anesthetic, and this can actually be potentially done in the psychiatrist's office. Now, that means the psychiatrist actually has to have the machine, which is expensive. But basically the difference is same kind of idea. We're just using magnetic stimulation or magnetic waves instead of electrical waves. And so that's designed to, again, restart the brain. So this is less invasive than the ECT. I've not seen any recent studies that shows the difference between ECT and TMS, probably because most people are really starting to push the TMS. Now, when you look at our first type of medication, our anti-anxiety medication, so this is going to be used with severe anxiety disorders, usually most likely your panic disorder, sometimes even your OCD and your PTSD. But basically, when we look at anti-anxiety medication, we're going to increase the level of GABA. By increasing the level of GABA, you're decreasing the likelihood of anxiety or panic attacks. The problem with this, though, this is highly addictive and highly abused if unregulated. Like when this first came out, this was thought to be a miracle drug, so they'd overprescribe Xanax and Ativan. The person would become addicted. They would need to use it daily, if not every 4 hours, to prevent their panic attacks. And really what's happening there, your body's realizing, okay, you're getting GABA from an outside source, so your brain will actually start to rewire some of your GABA transmitters or your GABA pathways to other things. And then what happens when they try to kick those drugs, now they're feeling constantly anxious. And so that becomes problematic. So these are more likely prescribed as a last-ditch effort at this point for anxiety, more likely for emergency purposes. Antidepressant drugs, these are now looked at as your SSRIs. Instead of elevating the levels of serotonin by providing synthetic serotonin, like your old antidepressants used to do, what we're looking at now in our new understanding of depression is necessarily your serotonin levels are not low, it's just the serotonin message does not get passed. Basically, what we look at, if we know, let's say you need 2 billion neurons activated with serotonin to feel happy, someone who's depressed is only making 1,000 of those neurons. Only 1,000 of those neurons are passing the serotonin or the happiness message. So what we look at trying to do is the SSRI will flood the body with these molecules. These molecules will block the reabsorption. And so now the serotonin molecules must bind, forcing the person to elevate mood. Now, unfortunately, what starts to happen is a lot of patients are now reporting, instead of feeling of happiness, they're getting a blunted emotional feeling. Now, that's not everybody, but it does tend to be a common side effect. So with the blunted emotional feeling, people will start to almost get sick of not having this emotion. I mean, emotion really gives us what we call the spice of life. I mean, the happy moments start to discount the bad moments and start to really make life worth living, essentially. So when the patient starts to have blunted feelings, they would rather feel something, even if it is sadness, and then go off the medication. But the problem is going off the medication can also increase those feelings of sadness, depression. And again, the big debate is serotonin levels. Are they that low? Since 1976, we've been tracking spinal fluid taps of chronically depressed patients, and we're not seeing the lower levels of serotonin that we thought. But that could be because they're just being reabsorbed too quick, and that's not really a low level of serotonin. Antipsychotic drugs, these are the most powerful type of psychopharmacology. Your classical antipsychotics, they're going to decrease the positive symptoms, which again, remember the delusions, the hallucinations, so we're decreasing dopamine. Your atypical antipsychotics, while having the same purpose, they're going to decrease dopamine. These are designed to attack the atypical antipsychotics. Difficult to treat both negative and positive symptoms because giving 2 antipsychotics can be detrimental to the body over a long period of time. Side effects are way more numerous and drastic, and the number one side effect we look at is what we call tardive dyskinesia. And tardive dyskinesia is just basically what we call medically induced Parkinson's symptoms. So they will have involuntary repetitive body movements, could be facial expressions, could be sticking out the tongue, could be anything. But the reason that is happening is because the medication is influencing the levels of dopamine. So what we do know now is if someone's treated with antipsychotic drugs long enough, they could develop what we call medically induced Parkinson's. And also what we're starting to see is Parkinson's patients are also now experiencing schizophrenic symptoms, hallucinations, based on their medicine for Parkinson's. And both of those medicines are designed to influence dopamine. So because those are happening with the disorder, we know dopamine can have drastic effects on the body when it's manipulated. So big thing to know is which medications are involved with which type of disorders. And then this tardive dyskinesia is a big one with schizophrenia.